Hello, my dear audience, and welcome to another episode of Let's Talk Micro. As always, I am so happy that you are here with me. Is this your first time listening to Let's Talk Micro? Well, welcome and thank you for choosing it as one of your podcasts. I know that you have many choices out there, so thank you. Okay, so I am not gonna keep you waiting. I know that you are jumping in because you want to learn about ESBL or learn about the new drugs out there for UTIs. So let me tell you a little bit about the episode and then we'll go ahead and jump into it. If you work in the lab, you're familiar with extended spectrum beta-lactamases, ESBLs. So in the episode, we talk a little bit about what ESBLs are, their impact. We talked about these new drugs that have been approved for urinary tract infections. And we also talk about E. coli sequence type 131 and its significance. And of course, in this episode, I am joined by Dr. Ashlan Kunz-Coyne, a great pharmacist. So let's go ahead and listen to it. So as you know, sometimes, well, from time to time, I like to do some episodes where I talk about some of the newer antibiotics. Sometimes, I do episodes about potential antibiotics. And this year, I was attending the MAD conference in Orlando, and in one of the talks, I was listening and I checked it out, and it was about some of the newer antibiotics. So I thought it would be a good topic to share with the audience. So with me today, I have a guest to talk about that. So with me, I have Dr. Ashlan Kunz. Dr. Kunz, welcome to Let's Talk Micro.
Thank you so much for having me. I'm excited to be here.
My pleasure. So let's go ahead and start with a quick introduction about what you do and anything else that you want to share with the audience.
Yeah, absolutely. So currently, I'm an assistant professor at the University of Kentucky College of Pharmacy. Been here for just 2 years now, but it's going by quick. Before I came to Kentucky, I did my PharmD at the University of Florida. I did PGY1, PGY2 at UF Health Jacksonville. PGY2 was in infectious diseases. And then I really thought at that point I was done with my training, but ended up in Detroit for a few more years for a postdoc research fellowship with Mike Rybeck, and that was health outcomes research and PKPD research. So that's really what brought me here. And now at UK, I have a research lab. We focus on resistant gram negatives and bacteriophage, so it's a lot of fun.
Indeed, and that's where actually I got my master's from the University of Florida. It's like such a beautiful campus, and I'm undergrad was UCF, and but definitely such a very like nice, and some of those buildings. It was a very nice campus there.
Yeah, absolutely. Yeah, we can say go Gators.
Yeah. Okay, so from the lab perspective, and we see in microbiology in the bench. We deal with a lot of ESBL, Enterobacterales, and so for the audience that's tuning in that maybe they don't have much of a lab background or they're maybe getting started on the field, let's start with some of the basics. So maybe you can start with explaining why the ESBL Enterobacterales, they're considered such a significant and growing public health threat.
Yeah. So ESBL or extended spectrum beta lactamases, they're enzymes that, like you said, are commonly found in Enterobacterales like E. coli, Klebsiella pneumoniae, and unfortunately, those enzymes can cleave our go-to beta lactams and render them ineffective. So, if you don't have some of these go-to beta lactam agents, you're really left with either broader spectrum beta-lactams, like our IV carbapenems, or you're left with quinolones, Bactrim. So, drugs that themselves have concerns. So, ESBLs are a public health concern for that reason, limiting treatment options, but also because times are changing. This 5, 10 years ago, you'd be concerned about an ESBL infection if, let's say, your patient was in the hospital or they were just in the hospital or they're from a nursing home or long-term care facility. But now we're seeing this community spread. So we're seeing patients coming in to a clinic, young, otherwise healthy patients coming into a clinic, and they end up having a UTI and it's an ESBL producing Enterobacterales. So we're kind of stuck in this situation where the agents are increasingly limited and we don't want to have to send our patients into the hospital if we don't have to, just so that they can get IV antibiotics.
Yeah, and that is so true. And from the lab perspective, typically, when you see these profiles, when you have like this resistant organisms, you tend to look at your patient demographics and you see, okay, older patient, nursing homes, and that typically checks out. They have some persistent infections, they've been treated multiple times. But when you see this younger people, let's say, and then you have this resistant profiles, it makes you think, okay, did something go wrong here? Do I have to maybe repeat this test? And but we do see that. So yes.
Yeah, and that's what's so sneaky about them is just their transmissibility out in the public.
Yeah, definitely. So I know that on your talk, you mentioned the E. coli sequence type 131. So let's go ahead and talk about this for a little bit for the audience. And what is the concern with this type? Regarding resistance and treatment.
Yeah, so sequence type 131 for E. coli, when we think on a global scale, this is really the dominant strain of E. coli that we're worried about. And what it's notorious for, it's notorious for being an ESBL producer. And we often associate it with CTXM, the most common, or, historically the most common ESBL enzyme that we see in our clinical isolate. So just like other ESBLs, super transmissible out in the public, and it comes with a very extensive resistance profile. So you might not only see some of your go-to beta lactams being resistant, but it can also defer resistance to your quinolones, your Bactrim, and again, your hands kind of become tied when it comes to options other than those IV carbapenem. So it's definitely a concern.
Okay. But one thing that we have been seeing when it comes to this, like later drugs, last resort, let's say drugs. So we're seeing a lot of these combinations, right? Where normally you see a drug by itself, then maybe you encounter this resistance, and then you combine it. Very popular, your beta-lactam, beta-lactamase, inhibitor combinations, and then combine, both of them. They have they produce a better result when it comes to resistance. So let's talk about cefepime and enmetazobactam. I know that we don't a lot we're familiar with cefepime, might not be that familiar with enmetazobactam, and then both of them combined. So maybe we can talk about a little bit about them, the activity they have, maybe separate, and then talk about their combined activity.
Yeah, yeah, definitely. So cefepime and enmetazobactam just recently FDA approved 2024 for our complicated UTI pyelonephritis infection. So like you mentioned, cefepime, that's a lot of people's go-to beta-lactam if susceptible in the hospital setting. So fourth generation cephalosporin, pretty decent stability against some of our AMP-C producing Enterobacterales, has activity against Pseudomonas. So oftentimes it's the empiric option. When you don't know what you're growing yet, that's a lot of people's go-to. But it's rendered ineffective with ESBL isolates. So enmetazobactam, you might notice some familiar name within enmetazobactam, which is tazobactam, but enmetazobactam is this novel beta-lactam, beta-lactamase inhibitor, and it has this N-methylated triazyl, so a positive charge on a triazyl, and what that does is it turns that molecule into a zwitterion. So compared to tazobactam, it has higher potency because it's able to better reach its target. Okay. So enmetazobactam with cefepime together has really excellent in vitro activity from what we've seen from thousands of tested isolates across the world so far. So 90, 95 or greater percent susceptibility against our ESBL producing isolates. It also has really great activity against AMP-C producers. So let's say, even though cefepime has pretty decent stability, let's say you have an isolate that is an AMP-C producer, resistant to cefepime, that combination with enmetazobactam is going to facilitate, hopefully, having susceptibility. And then so you get that class A coverage with your ESBLs, you get that class C coverage with your AMP-C producers. This is not a combination that you're going to use with class B with your metallo-beta-lactamase producers. This isn't the one for you. So no go on that. Maybe some use in the class D world with the oxotype enzymes. We really have limited data, just in vitro susceptibility data, and it did show potent activity against the OXA48 producer, so maybe in the future, but we don't have any clinical data to really back up the use of cefepime and enmetazobactam for our OXA48 producers. But, there's a chance maybe in the future. But um, for in vitro ESBL AMP-C, this is really going to be kind of one of the top options. Of clinical data, super limited. We have a clinical trial, the Allium trial, and it was evaluating patients with complicated UTI, pyelonephritis against piperacillin and tazobactam. And I'm sure a lot of people that have their well-founded reserves when it comes to using piperacillin and tazobactam for ESBL producing infections kind of, cringe a little bit. But in that study, cefepime and enmetazobactam did demonstrate non-inferiority and actually superiority to piperacillin and tazobactam. So that's how it kind of ended up with its FDA approval for complicated UTI and pyelonephritis. But all the agents that I talked about at MedID have the same recurring thing with clinical trial data, which is these agents should really be reserved for our ESBL producers, but we're only looking at about 20% of the isolates in the clinical trials actually being ESBL producers. So the data is still limited. Uh, Fortunately, the subgroup, when they looked at just ESBL producers, the subgroup analysis did hold up with cefepime and enmetazobactam. But again, we definitely need some more data to kind of back up efficacy for ESBL producers.
Okay. And and like you said, so this combination, should only be used. We need more information, but it should only be used for when you have a patient that has, like you said, a complicated UTI, and you have like an ESBL organism. So it shouldn't be like a first choice, let's say. So right.
Yeah, definitely. I mean, it's going to be your patients that are likely already in the hospital. You have culture and susceptibility data, and maybe you're down to, well, for some reason, either they can't tolerate the quinolone or the Bactrim, or maybe the quinolone Bactrim are both resistant. And so you're kind of down to the option of, do I give them the IV carbapenem, being meropenem or ertapenem, or do I give them cefepime enmetazobactam? So I think that's really the clinical scenario, that now you do have that non-carbapenem beta-lactam option. And we have other options, but the other options that we have are, I would hope, kind of reserved for our carbapenemase or metallobeta-lactamase producers. So cefepime and enmetazobactam definitely has a nice niche right now.
Okay. And when it comes to limitations, are there like any patient populations where you actually will avoid using this combination?
Just, right away you think of like cefepime or beta-lactam intolerance, so that doesn't change. But as far as like adverse effects, we're really only looking at diarrhea being the most common thing, so nothing different than our other antibiotics. Renal dose adjustments, just like you would with cefepime. So you could be thinking maybe alternative option if someone's in renal failure, but when when you're looking at your other options, this could still be the preferred agent. So nothing really otherwise that's kind of a red flag for me right now.
Okay, so thank you for that. So let's talk a little bit about sulopenem then now. And I did an episode about it with Sam Aiken. So it was a great episode, and I invite the audience to check it out where he like kind of went through it. So for sulopenem, when will you consider that a treatment option?
Yeah, sulopenem. So if you I'm gonna concur with you that if you haven't seen Sam's episode, definitely watch it, because I'm sure he goes into the weeds when it comes to the literature. But this is an agent that you absolutely need to be familiar with the literature, because it is right now the only FDA approved carbapenem that is available in oral formulation. So it's going to be an agent that's more readily available to outpatient, inpatient situations. And we need to make sure, of course, that we're using it appropriately. So the clinical data that we have we have trials for both uncomplicated UTI and complicated UTI. The two uncomplicated UTI trials compared it to either Cipro, Augmentin, and there's multiple nuances with those studies, but really the takeaway is that it showed non-inferiority in the uncomplicated UTI studies. It did not demonstrate non-inferiority when we were looking at the complicated UTI pyelonephritis. So non-inferior to Cipro, Augmentin, not non-inferior to ertapenem, and then, step down to oral therapy. So we're going to have multiple agents kind of coming to the market all at once for FDA approval with urinary tract infections, but sulopenem is the one we really want to keep in mind that clinical data supports its use for uncomplicated UTI. And really notably in the FDA approval, it clearly states, sulopenem should be considered in our adult female patients with uncomplicated UTI caused by E. coli, Klebsiella pneumoniae, Proteus mirabilis, that have no other options or have limited other options. So you're really looking at your quinolone susceptibility, your Bactrim susceptibility, your other beta-lactam susceptibility before you would make that leap to go with sulopenem. And gosh, UTI studies are always interesting because the comparison, even in the uncomplicated UTI study to Cipro, they broke down outcomes looking at Cipro susceptible and Cipro resistant, and the sulopenem was non-inferior when it was looking just at Cipro susceptible, okay, or Cipro resistant, I should say. But if you look at clinical cure rates for the patients that received Cipro, their clinical cure rates were pretty much the same whether or not their isolate was susceptible or resistant. So it kind of makes you scratch your head a little bit. We need more data in that space, obviously, but one recurring theme with sulopenem is that it had higher asymptomatic bacteriuria rates. So what that pretty much means is these clinical trials all had composite outcomes, and they were, clinical cure, did their signs and symptoms go away, or micro eradication, where they did a repeat culture. And sulopenem in more than one study kind of had that issue with not having a repeat negative culture. So something that will be interesting to see kind of moving forward when we have real world data of, are we having more patients coming back in for repeat or just needing other treatment for that total clinical cure. So it'll be interesting, but really the takeaway is sulopenem, uncomplicated UTI, uh, adult females that really have limited or no other options.
I like it. Thank you for bringing it back to the one place and kind of like summarize it. And
Yeah, yeah, because it's out of all the agents, the newer agents, like, it has some of the most clinical data, but even looking at that clinical data, it's like, "Whoa, gotta unpack a lot here."
yeah, yeah. Well, and then this next one, it's. I mean, it's interesting, and I kind of looked it up a little bit, and which is tebipenem, and I think I know I was researching, and maybe if you can talk a little bit about that too. I think it was FDA approved, but I see something about like a letter or something. But let's start with some basics. What is tebipenem?
Yeah. Yeah, tebipenem, so this is the other oral carbapenem. So, sulopenem is a thiopenem just because some structural changes, but tebipenem's a carbapenem. So they're both available oral. You're correct. It's not FDA approved yet, but it has some kind of structural changes compared to sulopenem. So it has a 1 beta methyl group. Pretty much just what that means is, unlike sulopenem, where it has to be co-formulated with probenecin in order to have high enough bioavailability, tebipenem, with that structural change on its own, it's able to hit our bioavailability goal. So that's one difference, but it's a carbapenem otherwise. Um, Limited data, of course, for what patient populations to use it in, but they're going for complicated UTI pyelonephritis. You're correct. There was a letter from the FDA. So tebipenem was tested against ertapenem for patients with complicated UTI pyelonephritis, and it did meet non-inferiority compared to ertapenem, but there were some nuances with the patients and isolates included. A lot of people bring up the fact that patients with enterococcal isolates were included. Well, an issue with that could be ertapenem doesn't cover enterococcus. So is it really a good comparison? And so kind of when you peel back looking at the isolates that were covered by both agents, do we lose that non-inferiority? So FDA pretty much said we need more clinical data from you all. So tebipenem was being tested against imipenem cilastatin, and actually at ID Week, there was an announcement that came out that the company had stopped the study early because of tebipenem efficacy. So it looks like positive data for tebipenem coming out of that study. I think things might move kind of quick now. It'll be interesting to see what unfolds in the next 6 months to a year. But yeah, the goal is complicated UTI pyelonephritis, and this is that other oral penem option. So.
One thing that you mentioned, and when we were talking, and I mentioned the episode that I did with Sam, and one of the things, you talk about the structure, going back to sulopenem real quick, because that was one of the things when he started talking. It's like, well, technically, like it is a penem, and he talked about the structure, and he went on this great explanation. So that came to mind as you were talking.
That's such a pharmacist thing, right? Like, sometimes you work with clinical pharmacists where they're like, "It's not a fluoroquinolone, it's a quinolone," just because those little structural changes, but yeah, same thing with sulopenem. It's a technically a thiopenem.
Yeah, no, it is such a fascinating aspect, and that's why I do enjoy when I'm talking to like ID pharmacists, and because they're so into what they do, and I love the nerdiness, and I love learning more about things, and then they go on these explanations and the way that we do the testing in the lab, and then they deal with the antibiotics and things like that, and just connecting those two is just so fascinating.
Yes, major props to the medicinal chemists that come up with these things because it is pretty amazing.
Yeah. Okay, so when it comes to, obviously, so we need more data and things like that. So when we're looking at these drugs, right, and say, okay, maybe it looks promising or it doesn't. So as of right now, when it comes to tebipenem for ESBL UTIs, so the take home is that we still need more data.
Yeah, the take home is it'll be nice to see the imipenem cilistatin data. It is an interesting comparator. I've never personally used imipenem cilistatin clinically, so it's like you said. I mean, if this drug gets approved, if it becomes available for use in the United States, then it really is our responsibility, the whole team. It's our responsibility to have tabs on this drug, have things in place like institutional guidance, different protocols, diagnostic stewardship. I mean, microbiology lab, definitely, you're probably bombarded with calls from clinicians like, can I get susceptibility testing on this isolate for what other drug? But being able to say, listen, it's susceptible to these other agents that are preferred based on policy and protocol at this institution. So, tebipenem wouldn't be your go-to in this situation. So, I think that we have a lot of work, and every institution is going to be a little different when it comes to how they approach both sulopenem and tebipenem if it gets approved. But the one thing that I always try to remind different institutions that maybe feel a little overwhelmed with how to start that process of getting it prepared for their site is we have a really amazing ID community that is more than willing to share their different guidance documents that they've made, their algorithms. So like, don't hesitate. Don't start from 0 and try to do it all yourself, and don't hesitate to reach out to other sites, to get their, pre-made things that you can just kinda edit to be appropriate for your institution. Because 'cause you're definitely not in this alone, and we're all gonna learn some important lessons along the way.
So true, and I always like to highlight that when I'm talking to people. As you mentioned with the community. so many people, they're willing to share, and that's a great way to put it. You are not alone. People are so nice. You see something, you reach out to them, and they're willing to work with you. So that's great.
Yeah, yeah, absolutely.
So any advice, and you touched a little bit on this, but when it comes to hospitals or ID pharmacists preparing to evaluate and potentially adopt these newer agents, any advice?
Yeah, it's gonna be do what you need to do to get everyone together for team training and on the same page. So I think that any clinician, whether ID or not, is bombarded with new data coming out every day. Like no one can keep up. You need a team to really to help you do it. And so because the data is going to very quickly grow for these agents, have a team compile the information, really the take home points, highlights of the data that we have, and do a structured group training so that every so that you're putting everyone on the same page when it comes to here's what we know, here's where it's appropriate to use, and this is what we don't know yet. So, if you're using it for other things, these are things that we need to really keep tabs on, document, so that we can get that data out there to the general population. So, it's all going to be team efforts in developing the protocols that you all agree with. Again, don't start at zero, and definitely include the microbiology lab, definitely include your ID stewardship, ASP, in with anything that has to do with these drugs. Include the experts, is what I'm trying to say, so that we can make sure that we're kind of hopefully putting our best foot forward.
Excellent. So before we kind of do like a closing remarks, let's say, I always like to ask this question. I didn't start doing it right away, but I've been doing it lately, and I enjoy hearing the different answers. So we tend to have this, this bug, this organism that we like it for many reasons. It could be it has like a sentimental, significance. Maybe someone did a paper on it. There's a mechanism. There's just the way that it looks, or the things that cause, that the diseases that it can cause, or things like that. So we all have that favorite bug. So what is your favorite bug?
Oh my goodness. 4 weeks ago, well, let's say maybe 2 years ago, I would have said Stenotrophomonas maltophilia, like hands down. And now that I work with it every single day in the lab, and now that it breaks my heart almost every single day in the lab, I'm still going to say it's my favorite because I'm always up for a challenge. But I'm so glad it's finally getting some attention because after working with daptomycin non-susceptible staph, vancomycin, daptomycin resistant enterococci, I mean, DTR, Pseudomonas, XDR, Acinetobacter, they all at least behave in the lab. If you want them to grow, they're going to grow for you. You can usually look at your preliminary data and say, this didn't kill, let's add these other things or let's change the dose and that'll kill them. Steno plays by no one's rules. If it doesn't want to grow, it's not going to grow. If you played it at 5 different dilutions, it might it might grow the same inoculum. It's amazing to me, and it's also very scary because prior to the last couple years, it hasn't been given much clinical attention, and we've been treating it the same way, which unfortunately we've shown, multiple labs have shown now could really be a problem. So, we have a long ways to go. The labs need funding when it comes to steno, but this is not a bug that I would take lightly based on, what we're seeing from multiple different labs coming out, what we see in the lab every single day. So I'm excited to hopefully, have some better therapeutics for steno moving forward.
Yeah, right. I mean, like from the get go, and just some basics, right? It's very resistant, in its nature. So you don't have that many options. And then when those are resistant, so that's just it is a problem. And yeah, from the lab perspective, if you think about maybe sometimes plating something like an E. coli, it works so well. Grows so healthy. You have like not even before 18 hours, you have like the very nice healthy growth. Steno grows a little bit slower sometimes, especially on McConkey. We have other non-fermenters. non-lactose fermenters growing, it can be challenging. It could be potentially missed.
Absolutely, and you hit the nail on the head, like, I can't tell you how many times I've said, "Oh, nothing's on the plate," after 18, 20 hours incubation. Okay, just let it go, give it its time. I mean, it could be 3 days later, and all of a sudden it pops up. Whereas any other isolate, you give it 18 hours and it would look just like that. So, or any other organism. So it's we there's so much we don't know about it. So like it keeps pulling me in, but it also is very frustrating. So, but you mentioned Sam. I mean, thankfully for Sam, he's been one of really the ID pharmacists that's kind of brought it back, brought attention back to the mainstream. So, I think we have the momentum right now that we have to keep going with it.
Okay, so it's still, because you mentioned like about 4 weeks ago, so it's still Stenotrophomonas, your favorite bug.
It is. I do. You might talk to me in a week, and I might be like red, waving the white flag.
Yeah, no, it's that is a good one. And and I mentioned this on the podcast I think a while ago, but I think one of the cool lab stories for me was that I once had a there was like a culture where there was like Pseudomonas aeruginosa, and then on one of the moldy IDs, Steno came back, and it was very hard to isolate. And looking at all the things and knowing that Steno was so resistant, what I did was like I did a swab and then I put a meropenem disc. I already knew the susceptibility for Pseudomonas, which was susceptible. That particular strain was susceptible to meropenem, and there it grew, right next to the disc. Sub it out, do testing, and then it was done.
Yeah, they're sneaky. They're very sneaky, and any lab assay that's typically, clean cut when it comes to reading results, Steno doesn't care. I mean, and people know, like, broth microdilution, difficult in general, a lot of manual labor, hard to read for a lot of bugs, and it's just escalated by Steno, so all good all around.
Yeah, definitely. So as we start to close the episode, is there anything else that you want to add about this, or anything else?
I mean, I'd end it with just saying, it's exciting this time because I really do think when I hear about sulopenem, tebipenem specifically, I think about those young females that, maybe they have the increased propensity to get UTIs. And I mean, that can be debilitating for patients. That can stop your daily routine flat out. So it is, in some way, positive to know that we could have an option for some people in an area that we otherwise have decreasing other oral options. So I'm I'm looking at it as hopefully a positive situation, but I think everyone that knows anything about these drugs and their use or approval overseas for some of them knows that we just have to make sure to work together to try to use them the best we can and make them so that we can use them long term for our patients. Yeah.
Well said. Well, this has been so great, and thank you so much for taking the time to be in Let's Talk Micro.
Thank you so much for having me. This is great. Love the podcast, and I really appreciate you having me on. So thank you.
My pleasure. Well, there you have it. I hope you enjoyed this great episode with Dr. Ashlan Kunz-Coyne. Definitely great content, and as I said before, in the lab you work with ESBLs, but learning more about this E. coli sequence type 131 and learning about these new drugs, it's very important as part of our job, knowing what's out there and how do these drugs work, and knowing about these antibiotics is very important. And I mentioned that I did an episode about sulopenem, so I am including the link in the show notes. And as always, you can find Let's Talk Micro on any podcast platform, Apple, Spotify, Amazon Music, Goodpods. So please subscribe, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much for the support. You can find Let's Talk Micro on all social media platforms. We have TikTok, YouTube, Instagram, and Blue Sky Social as Let's Talk Micro, X Let's Talk Micro 1, LinkedIn as Luis Plaza. There's the website, letstalkmicro.com. And if you have any feedback, any suggestions, you can do that, send us via social media or via email, letstalkmicro@outlook.com. Every suggestion, any feedback is always welcome and appreciated. And my dear Let's Talk Micro fans, I invite you to check out that episode from last week, which was sponsored by bioMérieux, a global innovator in infectious disease diagnostics. So please go ahead and support it. I am so happy that after so many years, I have an actual sponsor episode. So thank you, bioMérieux, for doing that. And I invite you, the audience, to please check it out. So download it and listen to it. It is great content. And if you want to support the podcast in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. And if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more. And they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And of course, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, is the end of this episode. I hope you enjoy learning about E. coli sequence type 131, about these new antibiotics, about ESBLs. As always, I enjoy sharing this information with you. And stay tuned, great things coming your way, great content. Thank you for the support. So please, continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.